Hello, I'm Dr. Tom Allison from the Mayo Clinic. I'm going to talk to you today about the evaluation of heart failure patients for heart transplant, and I title this View from the Exercise Lab. And that's because my primary role at Mayo is the director of the cardiopulmonary exercise testing laboratory. You can see I have appointments in adult and pediatric cardiology, professor of medicine, and also co-director of the sports cardiology clinic. I have no financial relationships to discuss and no off-label uses of pharmaceuticals or instruments. Using 3 exemplary cases, I'm going to discuss the process of evaluating patients with heart failure for possible cardiac transplant, and particularly focus in on the role of the cardiopulmonary exercise test. Let me start out by sharing my 3 rules of cardiology. Number 1, the patient is a used car, the stress test is a test drive. Number 2, fix the patient, not just the pictures. Number 3, we want to do something for the patient, not to the patient. So here's our first case. This is a 40-year-old male, and you can see he is presenting for evaluation in September of 2019. He has a family history of hypertrophic cardiomyopathy, but it's a mild form in his mother, and mother's uncle died of some unknown congenital cardiac defect. He's overweight but not obese. He had a heart murmur as a child, thought to be a VSD. He was asymptomatic. This was never imaged and resolved by age 20. 3 years prior, in April of 2016, he presented with a cough. An echocardiogram was performed showing concentric LVH with an ejection fraction of 30% and a question of non-compaction cardiomyopathy. Genetic testing was positive for a gene associated with hypertrophic cardiomyopathy. As we look further at his history, he had an ICD implanted for primary prevention, 2 inappropriate shocks, history of atrial fibrillation with 2 ablations. He's had 2 very, very brief episodes of AFib since the second ablation, well tolerated. He's relatively clinically stable, New York Heart Class probably 2, and AHA heart failure stage 3. You can see his medications there on the right. Here's his echocardiogram performed at the time of this visit. He's diagnosed with hypertrophic non-obstructive cardiomyopathy, but a low EF of 27% and general hypokinesis of the entire left ventricle. Right ventricle is normal. No comment on non-compaction. The second part of his evaluation is the cardiopulmonary exercise test. Here we can see a relatively unremarkable but not normal pre-exercise ECG. He has abnormal axis throughout. Voltages aren't particularly prominent. No arrhythmias or ST wave abnormalities. Exercise electrocardiogram gets to 117 heart rate on his medications. Nothing remarkable here either. However, on the cardiopulmonary exercise test, here is predicted maximal oxygen consumption. He achieves a very low percent of predicted. VO2 per heartbeat, or O2 pulse, is an analog of the stroke volume. That is also quite low. So his low peak VO2 is in large part due to limited cardiac output. It's just to show you a normal test for comparison. Hypertrophic cardiomyopathy is a relatively common genetic heart disease. Estimates as high as 1 in 500 live births. Complications include sudden death, embolic stroke, and atrial fibrillation. A small minority of patients burn out and become candidates for heart transplant. Here you can see the rates of progression from class 1-2 to class 3-4 is 1.6 to 7.4% per year, depending upon the degree of obstruction. His outcome, as ejection fraction spun down, his peak VO2 decreased, and finally, near the end, he developed an elevated VE/VCO2 slope. We know that this is a bad prognostic sign, indicative of pulmonary congestion. He received his heart transplant in August of 2021, has had 2 tests since then, improving VO2 and improving VE/VCO2. Note that heart transplant does not generally restore normal exercise capacity despite cardiac rehabilitation for all patients. Now, I recently reviewed the last 15 years of Mayo Clinic's transplant program. There have been 44 cases of transplant for reason of hypertrophic cardiomyopathy, about 9% of the transplants. Now here's our second case, another relatively young person, 30-year-old woman with a double inlet left ventricle and a hypoplastic right ventricle. Now she was operated on at Mayo in 1987, age 4. A classic Fontan was placed. It failed, and at age 10, she had another series of operations converting her to a lateral tunnel Fontan and had patch closure of her left AV valve, which we'll see in a moment. She presents in May of 2014 for consideration of combined heart and liver transplant. So here's the double inlet left ventricle. There's an L transposition, so the ventricles are switched left and right, whereas the arteries are in relatively normal position, although the aorta overrides the pulmonary artery. You can see the Fontan repair. Blood flow into the lungs is passive, as the superior and inferior vena cava are both attached to the pulmonary artery. There's nothing pumping blood into the lungs other than the muscle action of the legs during exercise. Echocardiogram, unless you do this kind of practice, you may not instantly recognize things, but quick walkthrough. Here's the common double inlet left ventricle, right AV valve, left AV valve has been closed with a patch. Down here, we can't really see it well, but here is the hypoplastic right ventricle, the outflow tract, and the aortic valve. This is the common atrium with no septum, and here we see part of the structure of the Fontan. In addition to the structural defects, this patient also had history of PSVT requiring amiodarone, sinus node dysfunction requiring a pacemaker. The atrial lead could be placed. The ventricle could not be reached percutaneously. Cardiopulmonary exercise test. Here we can see the atrial pacing lead. We have a common ventricle. There's no R-wave progression here. Large left ventricle with strain pattern. With exercise, normal atrial conduction takes over. No ventricular arrhythmias, nothing remarkable on the exercise ECG. Peak oxygen consumption, extremely low compared to predicted. Now you say, Well, I thought the left ventricle was pumping pretty well here. Well, here the low cardiac output and low stroke volume are a result of impaired blood flow into and through the lungs. So this isn't a problem with LV pumping, this is a problem with LV filling. The patient had been followed since 2006 with serial exercise testing, and you can see a gradual reduction in the peak VO2 until the test that I just reviewed with you. VEVCO2 remains relatively normal since there's not fluid backing up into the lungs. The problem rather is getting blood into the lungs, not getting out of the lungs. The epidemiology of congenital heart disease begins with initial identification in the 19th century, palliative shunts, cardiopulmonary bypass, and a variety of neonatal surgeries being developed in the second half of the 20th century. Though congenital heart disease occurs in 1% of live births, we now see that 90% of those babies survive into adulthood. This translates into 1.9 million Americans with adult congenital heart disease. Survival in adult congenital heart disease is impaired due to arrhythmias, heart failure, endocarditis, and issues with pregnancy. How about the outcome of our patient? Well, she finally, after a long wait, got her heart and liver. She was transplanted in September of 2018. A few weeks later, had a septal myectomy and tricuspid annuloplasty on the donor heart. Started cardiac rehab in December. Took a little break for removal of a mediastinal hematoma. Ultimately completed an extended course of cardiac rehabilitation. 67 cases, or 13.5% of our transplants in the last 15 years have been for congenital heart disease. After the transplant, she's had several serial exercise tests, again, continued residual impairment on the exercise test, chronotropic incompetence, weight gain, skeletal muscle weakness from corticosteroids and other immunosuppressives. Let's look at our final case. This is a young athletic female presenting in 2017 at age 12 for syncope. She does figure skating, volleyball, and basketball. There's a strong maternal history of arrhythmogenic right ventricular cardiomyopathy. Her mother is gene positive but phenotype negative, but there are multiple extended family members with ICD. Her workup included genetic analysis, and she is also positive for the PKP2 gene. She had a prior evaluation at age 9, which was entirely normal. And that's typical of the epidemiology of ARVC, that it manifests between the second and fourth decades of life. Sudden death, heart failure, transplant are consequences of ARVC. We diagnose it by T-wave inversions, ventricular arrhythmias, and RV enlargement and reduced function. You see here, it's frequency more common in Germany and Italy, first identified in 1982 while studying Naxos syndrome, definition standardized 1994. Here's a very prototypical case. This isn't our young lady, but another patient from our lab. You can see arrhythmias at rest, T-wave, prominent T-wave inversions out to V4, and ventricular tachycardia with exercise. There's a concern about her athletics because exercise training, particular endurance training, may produce more RV dilatation and accelerate the course of ARVC. Now let's go back to her evaluation. Resting ECG, cardiac MR, she's got moderate RV enlargement with an EF of 30%, borderline positive for non-compaction with apical trabeculations, and a normal LVEF. On her cardiopulmonary exercise test, you can see she has the pattern of T-wave inversion out to V4, some resting ectopy, relatively unremarkable exercise response, and more ectopy in active recovery. Her performance on the test was remarkably good, better than expected for age, both in terms of her peak oxygen consumption and her oxygen pulse. Despite this excellent response, her clinical course progressed rapidly. Increased RV enlargement, tricuspid regurgitation. She remained asymptomatic or only minimally symptomatic, but ultimately ventricular arrhythmia load increased, placed on metoprolol, then sotalol, ICD was implanted, and she underwent heart transplantation in September of 2017, and that was just 2 years, less than 2 years after this evaluation. Here we can see her normal echo on the left, the echo from this evaluation in the middle, and prior to her transplant. You can see the progression of RV dysfunction. Probably easiest to look at the right atrium to see that, how big it's gotten, and increased tricuspid regurgitation over the same time period, particularly between August of 2014 and December of 2017. After this initially good performance, her peak VO2 began to decrease. VEV-CO2 nadir increased. She had her transplant, had one early test when she completed cardiac rehab, has not had another test. We think she's doing well because she's back to figure skating, volleyball, and now track. Peak VO2 is likely increased. In the 15 years of transplant I reviewed, only 8 cases had ARVC as the reason for transplant. So, to finish up my take-home points, there are many cases of heart failure, or not many cases, yes, many cases and many causes of heart failure leading to transplant. Heart failure and transplant do occur in athletes. The cardiopulmonary exercise test is an important tool for assisting in the timing of transplant. Cardiac transplant improves survival and reduces symptoms of daily living, but does not normally restore exercise capacity. Usually patients are back to about 65 to 70%, and their peak VO2 occurs at about 2 years post-transplant. Rare to see them exceed 100% of predicted. Usually that's with a short course of heart failure and an aggressive exercise program. Thank you.